Now, it's all very well knowing how to treat multi-drug resistant TB, but there are practical problems, aren't there? Tell me about the ones that you've been looking at.
Right. So they're very practical problems. I mean, the first issue is finding the patients who are actually infected with a drug-resistant strain, and that requires more complex laboratory capacity, and that's why worldwide we're often only finding 20% of estimated cases are being detected.
Why is that? Why is it so low?
Well, because you can't just assume that someone who has tuberculosis has drug-resistant tuberculosis without actually testing the strain of the bug that's causing disease to find out which antibiotics it works against and which ones it doesn't work against.
Now, tell me about the techniques you're using, like the Bangladesh regimen, that could possibly improve things.
Right. Well, so the Bangladesh regimen, what it's trying to address is the fact that the current treatment is grueling and it's toxic. It's 18 to 24 months of treatment, often involves daily injections, sometimes for 4-6 months of treatment. And that treatment is so grueling that people often don't stay in for the full course.
And you can get very deaf with this treatment, can't you?
In fact, it's one of the most concerning side effects of the current treatment. The injectable compound that's used to treat drug-resistant tuberculosis can cause deafness, which is often permanent. In some cases, 30-40% of patients might end up deaf. And that's really a shocking and a tragic side effect of the treatment.
And so your solution is what?
Well, so we've witnessed that in Bangladesh, a regimen has been used, is much shorter, less toxic to patients. We call it the Bangladesh regimen. It's a 9-month treatment regimen that showed really promising results in that country.
What are the main differences?
Well, the main differences of the Bangladesh regimen are duration. So instead of 24 months, you're talking about 9 months, which is obviously a huge difference for patients and for the health system that has to implement it.
And you're now conducting randomized controlled trials in 4 countries. Tell me what's happening.
Right. So the issue is, even though it worked well in Bangladesh, we have to show that it can work well in other countries. We have to show that it can work well in HIV-infected populations, which didn't happen in Bangladesh. And importantly, we have to compare it head-to-head with the current treatment to show that it works. So with support from USAID, we were able to initiate a randomized controlled trial comparing the Bangladesh regimen to the 9-month regimen in 4 countries, and that's what we're doing right now.
Of course, you don't have the answers yet, but what are your feelings about what this might yield if you're very successful?
Well, we're hopeful. We're hopeful based on the results we've seen in Bangladesh, as well as some other cohort studies of this same regimen in Africa, which the Union is supporting. So we are hopeful. The ultimate answer won't be available till the clinical trial is done in 2017.
Is there a chance of having new regimens with new agents?
Well, there's also promise on that side as well. There's new compounds for the first time in 40, 50 years in tuberculosis control. One new drug called bedaquiline has been conditionally approved, and we're actually exploring whether we can bring that drug into the clinical trial and expand the trial to evaluate other treatment regimens.
Now, how do you implement these things? Because you've got a mountain to climb in terms of getting that detection, the case detection rate up. And
Right.
You've got a lot of governments and organizations and the community to talk to. What are the practicalities of all of this?
Right. Well, the implementation phase of MDR-TB treatment is really challenging, and it involves both strengthening laboratory capacity, it involves strengthening the program to be able to implement a complicated regimen. There's drug supply issues in terms of ensuring that the right drugs are delivered to the country and delivered to the sites in a timely way. So it's a complex process.
Sounds expensive though.
Well, it is expensive on one level, but the reality is that the shortened regimen that we're testing is actually much cheaper than the currently used treatment. So not only is it a cheaper regimen, we think it will also be more effective, and in the long run, far more cost effective for programs.
So as a TB specialist, how would you motivate organizations, communities and governments? What's your special idea?
I think those stakeholders, especially governments, are very anxious to get an answer, get a solution that is implementable for them. And so I think they're very supportive of the clinical trial where we're working. They want the results, and I think that international bodies such as the WHO are very keen to translate those results into guidelines for new policies on drug.
So what's the bottom line message?
The bottom line message is the current status is very difficult in terms of treatment for MDR-TB, but we're hopeful through research we can generate the evidence to change that to more tolerable solutions for patients and programs.
And if you were to leave clinicians and communities and indeed planners and governments with just a brief thought about what you think is the top issue they should concentrate on, what would that be?
Well, actually, it might be surprising, but our answer from the union as a tuberculosis control organization is don't forget the basics. So we need to address drug-resistant tuberculosis, but if we take our eye off the basic tuberculosis control program for regular drug-sensitive tuberculosis, we could find ourselves in more trouble down the road than we are right now.
Thank you very much.